What is a psychological disorder? Unit 2 Disorders of anxiety, fear, panic, and obsessions. 2.0 Introduction. We often become anxious in our day-to-day life situations, such as when we have to appear for an exam, job interview, or caught in a traffic jam while already running late, trying to meet the deadlines, etc. Our level of anxiety decreases once we come out of such situations. However, it is important to look at certain situations when the individual remains anxious irrespective of the situation and is unable to cope with it. When this happens, the person is said to be suffering from anxiety disorder. There are several anxiety disorders that have been identified by DSM-5, like generalized anxiety disorder, specific phobia, social phobia, panic disorder, and agoraphobia. In this unit, you will learn the clinical aspects, causal factors, and treatment of specific phobia, social phobia, panic disorder, and agoraphobia. You will learn about generalized anxiety disorder and obsessive compulsive disorders in the subsequent unit. But before we delve further into these disorders, let us first understand about anxiety and other similar conditions such as fear and panic. 2.1 Distinction between anxiety, fear, and panic. The most common way to distinguish fear and anxiety has been in the terms of an actual external stimulus that is perceived as a real danger, threat by most people. Fear is experienced in the presence of real danger, threat, whereas anxiety is experienced only in anticipation of danger, threat when such a danger, threat is not present or cannot be specified. Several researchers have distinguished between fear, panic, and anxiety in terms of cognitive, subjective, physiological, and behavioral components, e.g., Barlow, 2002, Boughton, 2005, and Grillin, 2008. These components are loosely associated, i.e., every individual may not necessarily experience all the three components. Thus, someone having fear or anxiety may experience cognitive and physiological component with greater intensity than the behavioral component and vice versa. Big 2.1 Components of fear. Panic, like fear, has all the above three components. However, additionally, panic attack is characterized by subjective feelings of impending doom, fear of dying, going crazy, and losing control. Anxiety, on the other hand, is a more diffused, future-oriented state that comprises of a complex blend of cognitions and emotions. Fig. 2.2 Components of anxiety. Cognitive, subjective. I am afraid. Physiological. Increased heart rate, fast and heavy breathing. Behavioral. Strong urge to escape from the situation. Cognitive, subjective. Negative mood, worry about possible future danger, threat, self-preoccupation, inability to predict and/or control the occurrence of future danger, threat. Physiological. Chronic tension and over-arousal, full-fledged fight or flight response is not there as in fear, but the person is primed for fight or flight response for the anticipated danger. Behavioral. Avoidance of anticipated dangerous, threatening situations, but there is no immediate urgency to escape as in fear. 49. Disorder. 2.2 Clinical features of phobia. A phobia is a persistent and disproportionate fear of a specific object or situation that presents little or no actual danger to a person. Carson, Butcher, and Manika, 2003. DSM-5 has identified three categories of phobias: specific phobia, social phobia, and agoraphobia. According to DSM-5, specific phobia, previously known as simple phobia, has 5 subtypes: animals, e.g., snakes, spiders, dogs; natural environment, e.g., water, heights, storms, blood injection injury; situational, bridges, tunnels; others, vomiting, choking; space phobia, where the person has a fear of falling down if she is away from walls or support. Social phobia is a fear of social situations. A person is afraid of acting in a humiliating or embarrassing way when she is exposed to the scrutiny of others. Social phobia may be specific to a situation such as fear of public speaking or generalized as in fear of many different social interactions. Agoraphobia was traditionally thought to be a fear of agora, Greek word for public places of assembly, Marx, 1987. It is a fear of crowded places such as shopping malls, theaters, etc. It can also be a fear of having a panic attack in situations where escape might prove to be difficult or embarrassing. Now, we will discuss the above-mentioned phobias separately. Specific phobias. Specific phobia is diagnosed when a person shows strong and persistent fear which is triggered by a specific object or situation. On encountering a phobic stimulus, the person with specific phobia show an immediate fear response that resembles a panic attack except for the presence of a clear external trigger. APA, 2013. He experiences anxiety on anticipation of the phobic stimulus and go to great lengths to avoid it. The person is fearful and avoids even the mere representations, picture, model, of the phobic stimulus. Most often, the person has an insight about one's condition, that is, the person recognizes that the response to a phobic stimulus is unreasonable or excessive. 50. Box 2.1. Criteria for specific phobia according to DSM-5, APA, 2013. A marked and persistent fear that is excessive or unreasonable, cued by the presence or anticipation of a specific object or situation, e.g., flying, heights, animals, receiving an injection, seeing blood. B. Exposure to the phobic stimulus almost invariably provokes an immediate anxiety response, which may take the form of a situationally bound or situationally predisposed panic attack. Note: in children, the anxiety may be expressed by crying, tantrums, freezing, or clinging. C. The person recognizes that the fear is excessive or unreasonable. Note: in children, this feature may be absent. D. The phobic situations is avoided or else is endured with intense anxiety or distress. E. The avoidance, anxious anticipation, or distress in the feared situations interferes significantly with the person's normal routine, occupational or academic functioning, or social activities or relationships, or there is marked distress about having the phobia. F. In individuals under age 18 years, the duration is at least 6 months. G. The anxiety, panic attacks, or phobic avoidance associated with the specific object or situation are not better accounted for by another mental disorder, such as obsessive-compulsive disorder, e.g., fear of dirt in someone with an obsession about contamination, post-traumatic stress disorder, e.g. Avoidance of stimuli associated with a severe stressor, separation anxiety disorder, example, avoidance of school, social phobia, example, avoidance of social situations because of fear of embarrassment, panic disorder with agoraphobia, or agoraphobia without history of panic disorder. Types of specific phobias. DSM-5 defines 5 types of specific phobias. 1. Animal type. These include fears of animals such as dogs, cats, spiders, bugs, mice, rats, birds, fish, and snakes. 2. Natural environment type. These include fears of heights, storms, and being near water. 3. Blood injection injury type. These include fears of seeing blood, receiving a blood test or injection, watching medical procedures on television, and for some individuals, even just talking about medical procedures. 4. Situational type. These include fears of situations such as driving, flying, elevators, and enclosed places. 5. Other type. These include other specific fears, including fears of choking or vomiting after eating certain foods, fears of balloons breaking or other loud sounds, or fears of clowns. 51. Disorders of anxiety, panic, and obsessions. Comorbidity. People who suffer from specific phobia are likely to suffer from other anxiety disorders also. Crum and Pratt, 2001. Prevalence, age of onset, and gender differences. Lifetime prevalence for specific phobias is 12%, which implies that these phobias are quite common. Kessler, Chiru et al. 2005 c. In India, however, prevalence rate has been reported to be 4.2%, which is significantly lower as compared to other countries. Chandrasekhar and Reddy, 1998. Despite being very common, people with specific phobias are less likely to seek treatment than people with other anxiety disorders. The most common specific phobias are fears of spiders, snakes, and heights. Phobias also depend on culture. Example, in China, Pelang is a fear of cold, in which the person fears that loss of body heat may be life-threatening. The age of onset for specific phobias varies depending on the fear. Animal phobias, storm phobias, blood injection injury phobias and dental phobias typically begin in early childhood. The average age of onset for height phobias is in the teens, whereas specific phobias of enclosed places, claustrophobia, and driving phobia often begin in adolescence and early adulthood. Barlow, 2002. Some specific phobias, example, spiders, storms, are much more common among women than men, whereas others, example, blood phobias, are more equally found in men and women. Lifetime prevalence is about 7% for men and 16% for women. Kessler et al., 1994. General characteristics of people with phobias. People with phobias usually know that their fears are somewhat irrational, but they cannot help themselves. If they attempt to approach the phobic situation, they are overcome with fear or anxiety, which may vary from mild feelings of apprehension and distress to a full-fledged activation of the fight or flight response very similar to panic attack. Phobic behavior tends to be reinforced by the reduction in anxiety that occurs each time a feared situation is avoided. And phobias may sometimes be maintained by secondary gains, such as increased attention, sympathy, and some control over the behavior of others. These benefits are usually not in awareness of the sufferer. 2.3 Why do phobias develop? The causes of specific phobias are complex, involving biological factors, a history of negative experiences in the feared situation as well as other psychological factors and evolutionary factors. Biological perspective. Genetic factors. The speed and strength of conditioning of fear is determined by genetic and temperamental variables. Hetima et al., 2003. Olberg and Manica, 2011. This means that phobias are acquired as a result of genetic makeup or temperament and personality. People who are carriers of one of the two variants on the serotonin transporter gene, which is linked to high neuroticism, are more likely to be conditioned to fear stimuli. Lonsdorf et al., 2009. Related to the findings, Kagan et al., 2001, reported that behaviorally inhibited, shy, timid toddlers showed a higher risk for the development of multiple specific phobias at 7 to 8 years of age than were uninhibited toddlers. Studies have also indicated a modest genetic contribution. For example, Fire et al., 1995, reported an elevated risk of specific phobias in first-degree relatives of those who had been diagnosed with specific phobia. Twin studies on females and males found a higher concordance rate for animal phobias in MZ than DZ twins. Kendler et al., 1999, Hetima et al., 2005. The same studies have also reported the effect of the non-shared environment on the origin of specific phobias, which implies the role of other factors, such as psychological and socio-cultural, in the acquisition of specific phobias. Psychological perspective. Psychoanalytic viewpoint. According to Freud, phobias represent a defense against anxiety that stems from repressed impulses of the id. As it is too dangerous to know the repressed id impulse, the anxiety is displaced, defense mechanism, displacement, onto an external object or situation that has some symbolic relationship to the feared object. Freud, 1909, explained the development of phobia with the case study of little Hans, a 5-year-old boy with a phobia of horses. Freud suggested that Hans's phobia was developed as a result of anxiety due to Oedipus complex. Hans unconsciously hated his father and wanted to kill him and possess his mother. This led to a fear in Hans that his father would kill or castrate him for having such negative feelings. Since these unconscious conflicting thoughts were not acceptable to the conscious mind, the anxiety created was displaced onto horses as these symbolically represented his father. This explanation was criticized as being far too speculative by many researchers, and an alternative explanation of Hans' phobia in terms of the learning theory was provided by behavioral theorists. Behavioral perspective. In the development of phobias, the behavioral theorists focus on learned behavior. Wolpe and Rachman in 1960 suggested that Hans' horse phobia originated from an instance of traumatic classical conditioning. He had witnessed an accident in which a horse was badly hurt. It upset him so much that he started to avoid leaving the house so as not to encounter the horses in the street. Several research studies by other theorists also supported the role of classical conditioning principles in acquisition of phobias. An individual learns to fear a previously neutral stimulus which is paired with a noxious object or event. Once a phobia is acquired, it gets generalized to similar objects or events. In a survey conducted by OSR and Hugdahl, 1981, 58% of the respondents attributed their phobia to a traumatic conditioning situation. Further, direct conditioning may be especially common in the onset of dental phobia, Kent, 1997, claustrophobia, Rachman, 1997, and accident phobia, Kuch, 1997. Vicarious or observational learning. Phobias can be acquired by merely observing another person who acts fearfully to a given object or situation, Austin Hugdahl, 1981. For example, lab-reared rhesus monkeys who were not initially afraid of snakes rapidly developed phobia of snakes after observing their wild-reared counterparts behaving fearfully with snakes, Manika and Cook, 1993. Similar observations were reported when lab-reared monkeys watched the videotape of wild-reared monkeys behaving fearfully. 53. Disorders of anxiety, panic and obsessions I. With snakes. This implies that phobias can be developed through mass media also, Manika and Sutton, 2006. This involves informational learning where an individual learns to fear a particular object or situation by hearing or reading that the situation is dangerous, for example, learning to fear flying by hearing about plane crashes in the news, or learning to fear driving by continually receiving warnings from others that driving is dangerous. Cognitive perspective. Cognitive factors, such as attention, memory, cognitive biases help to maintain the phobias that have been acquired. Generally, people with specific phobias tend to pay more attention to threatening information that relates to their fear, Manika, 1992. For example, individuals with spider phobias are often the first people to spot a spider if there is one in the room. People with phobias also tend to have distortions in their memories for encounters with the objects and situations they fear. For example, people with an animal phobia may remember the animal that they have encountered as larger, faster, or more frightening than it was. Further, people with specific phobias tend to hold beliefs and to interpret situations in such a way as to maintain or increase their anxiety, Oman and Manika, 1999. For example, people with a fear of height may assume that they are more likely to fall. People who fear enclosed places, such as elevators, may believe that they will run out of air, or that they will be unable to escape. Lastly, avoidance of feared situations prevents people with specific phobias from learning that the situations they fear are not as dangerous as they feel. In addition, relying on safety behaviors, example, driving extra slowly to avoid an accident, always wearing shoes to prevent insects from touching one's feet, can also help to maintain a person's fears. Evolutionary perspective. Our evolutionary history has affected which stimuli are likely to be feared. Example, snakes, water, heights, enclosed spaces are more likely to be objects of fear than bicycles, knives, cars, even though the latter objects may be at least as likely to be associated with trauma. Primates and humans have a biological preparedness to rapidly associate certain kinds of objects such as snakes, spiders, water and enclosed spaces with aversive events. It has been suggested that this preparedness may have been a selective advantage, example, helped in survival, for our ancestors in the course of evolution, Manika and Oman, 2002. Oman, 1996, has provided two lines of evidence to support the preparedness theory of phobias. First, in case of human participants, fear was conditioned more effectively to fear relevant stimuli such as snakes and spiders than to fear irrelevant stimuli such as flowers and vegetables. In case of primates, lab-reared monkeys with no prior experience to fear relevant stimuli also showed conditioning for fearing relevant than irrelevant stimuli. 2.4 Treatment of Phobia. The main treatment options for phobia are as follows. Exposure therapy. The client is exposed to the feared object, animal, or place in a controlled environment. Choi et al., 2007. There are various forms of the exposure therapy, for example, systematic desensitization, flooding, virtual reality. Systematic. 54. Introduction to psychological disorders and disorders of anxiety and obsessions. Desensitization is based on the premise that one cannot be anxious and relaxed at the same time. It is conducted in several steps. Firstly, with the help of client, a hierarchy of the fear-eliciting situation is formed, beginning from the least fear-producing to the most fear-producing situation. Example, dog barking in the next lane to the dog barking just in front of the client. Secondly, the client is taught relaxation exercises, such as progressive muscle relaxation, deep breathing. Then the person is asked to relax and imagine the fear-producing situation in the ascending order of the hierarchy, beginning from the least fear-producing situation. Gradually, the client learns to relax in the most fear-producing situation, thereby extinguishing phobia. An opposite of this technique is flooding, where the client is exposed to the most fear-producing situation and is taught that she can go through the fear-producing situation without being harmed, contrary to her expectation of getting hurt. Earlier therapists used the real situations or imagination, if the situation was hazardous, whereas now therapists use virtual reality. In this type of therapy, the therapists with the help of computers and other equipment simulate the fear-producing situation. Example, heights, air travel, and the client is exposed to the simulation exercise. Through all these techniques, the client realizes the irrationality of her fear, and thus the fear gets extinct. Modeling. Based on Bandura's 1977 vicarious learning theory, the client either observes another person, sometimes the therapist, in real life or in a movie, acting fearlessly in a situation that causes phobia in the client. By watching another person acting fearlessly and calmly, the client also learns that the phobic situation or the stimulus is harmless, which helps to treat phobia. While the behavior therapies have been found to be effective in treating phobia, medication and cognitive techniques, such as cognitive restructuring, have not been found to be effective. According to the recent findings, a drug called D-cycloserine, when used in conjunction with exposure therapies like virtual reality, has been found to increase the effectiveness of exposure therapies. Norberg et al. 2008. Clinical features of social anxiety disorder, social phobia. Social phobia is a persistent, irrational fear generally linked to the presence of other people. It can be extremely debilitating. What is the difference between social phobia and social anxiety disorder? The difference between social phobia and social anxiety disorder, SAD, is largely chronological, in that social phobia is the former term and SAD is the current term for the disorder. The official psychiatric diagnosis of social phobia was introduced in the third edition of the Diagnostic and Statistical Manual, DSM-3. Social phobia was described as a fear of performance situations and did not include fears of less formal situations such as casual conversations. DSM-5 describes social anxiety disorder as disabling fears of one or more specific social situations, such as public speaking, urinating in a public bathroom, or eating or writing in public, where the person fears of being exposed to the scrutiny and potential negative evaluation of others, or that she may act in an embarrassing or humiliating manner. Therefore, the person tries to avoid such social situations, or when avoidance is not possible, endures them with great distress. There are two subtypes of SAD according to DSM-5. One is specific to performance situations, example, public speaking, and the other is general or in non-performance situations, example, eating in public. Box 2.2. Criteria for social anxiety disorder according to DSM-5, APA, 2013. A marked or persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way, or show anxiety symptoms, that will be humiliating or embarrassing. Note: in children, there must be evidence of the capacity for age-appropriate social relationships with familiar people, and the anxiety must occur in peer settings, not just in interactions with adults. B. Exposure to the feared social situation almost invariably provokes anxiety, which may take the form of a situationally bound or situationally predisposed panic attack. Note: in children, the anxiety may be expressed by crying, tantrums, freezing, or shrinking from social situations with unfamiliar people. C. The person recognizes that the fear is excessive or unreasonable. Note: in children, this feature may be absent. D. The feared social or performance situations are avoided or else are endured with intense anxiety or distress. E. The avoidance, anxious anticipation, or distress in the feared social or performance situations interferes significantly with the person's normal routine, occupational, academic, functioning, or social activities or relationships, or there is marked distress about having the phobia. F. In individuals under age 18 years, the duration is at least 6 months. G. The fear or avoidance is not due to the direct physiological effects of a substance, example, a drug of abuse, a medication, or a general medical condition, and is not better accounted for by another mental disorder, example, panic disorder with or without agoraphobia, separation anxiety disorder, body dysmorphic disorder, a pervasive developmental disorder, or schizoid personality disorder. H. If a general medical condition or another mental disorder is present, the fear in criterion A is unrelated to it. Example, the fear is not of stuttering, trembling in Parkinson's disease, or exhibiting abnormal eating behavior in anorexia nervosa or bulimia nervosa. Comorbidity. People who suffer from SAD are also likely to suffer from one or more anxiety disorders and depressive disorder. Ruscio et al., 2008. Generalized SAD has been found to be comorbid with depression and alcohol abuse. Witchen, Stein, and Kessler, 1999. Specific SAD is comorbid with GAD, specific phobias, panic disorder, avoidant personality disorder, mood disorders and alcohol abuse. Crum and Pratt, 2001. Prevalence, age of onset, gender differences and cultural factors. SAD is common and found even in public celebrities, for example, Barbara Streisand, American actor and singer. Its lifetime prevalence is 12% of a given population. Ruscio et al., 2008. In India, prevalence rate of 12.8% has been found in the adolescents. Mahatalia and Vankar, 2004. It is a persistent disorder with spontaneous recovery shown by only 37% of the sufferers over 12 years. Bruce et al., 2005. SAD usually begins during early or middle adolescence or early adulthood. Ruscio et al., 2008. SAD is more common among women than men, as 60% of the women have been reported to suffer from the disorder. SAD is also affected by cultural factors. Example, in Japan, fear of giving offense to others is very important, whereas in USA, fear of being negatively evaluated by others is a source of social anxiety. General characteristics of people with SAD: the individual usually tries to avoid situations in which he might be evaluated and reveal signs of anxiousness or behave in an embarrassing way. Fears concerning excessive sweating or blushing are common. Speaking, performing in public, eating in public, using public lavatories, etc. can elicit extreme anxiety, and they often work in occupations or professions far below their talent or intelligence because their extreme social sensitivity does not allow them to work in situations which involve interactions with people. 2.6 Causal factors for social anxiety disorder. Let us understand the causal factors for social anxiety disorder. Biological perspective: genetic and temperamental factors. Results from a very large study of female twins suggests a variance of 30% due to genetic component in development of SAD, Smoller and others, 2008. Family studies also show that first-degree relatives of proband were more than 2 to 3 times as likely to also share a diagnosis. Further, infants easily distressed by unfamiliar stimuli are at an increased risk for becoming fearful during childhood and by adolescence, show increased risk of developing social phobia. Kagan, 1997. 57. Disorders of anxiety, panic and obsessions. I. Psychological perspective: behavioral explanation. SAD in many cases as a result of direct or vicarious classical conditioning. In a study, 56% of people with specific SAD and 44% with generalized SAD reported direct traumatic conditioning experiences. Townsley and others, 1995. People with generalized SAD may be especially likely to have grown up with parents who were socially isolated or who devalued sociability, thus providing ample opportunity for vicarious learning. Rosenbaum and others, 1994. Also, many people with social phobia reported to develop it while having problems in fitting in within their peer group. Harvey and others, 2005. Cognitive factors. Socially anxious people are more concerned about evaluation than people who are not anxious. Goldfried, Padawar, and Robbins, 1984. And are more aware of the image they present to others. Bates, 1990. They tend to view themselves negatively even when they have actually performed well in social interactions. Wallace and Alden, 1997. In a study by Davison and Zighelboim, 1987, which used articulated thoughts in simulated situations, it was reported that people with social phobia showed more negative articulated thoughts in a stressful situation in comparison to people without social phobia. Persistent and irrational fears actually occurs because fear is elicited through early automatic processes that are not available to conscious awareness. After this initial processing, the stimulus is avoided, so it is not processed fully enough to allow the fear to extinguish. Amir, FOA, and Coles, 1998. Social Skills Deficit Model. According to this model, inappropriate behavior or a lack of social skills is the cause of social anxiety. The individual has not learned how to behave so that she feels comfortable with others. The person repeatedly commits faux pas, tactless mistake. Person is awkward and socially inept, often criticized by social companions. Support for this model comes from findings that socially anxious people are indeed rated as being low in social skills. 20man and McFall, 1975. Perception of uncontrollability and unpredictability. Submissive and unassertive behavior, which is a characteristic feature of people with social phobia as a result of uncontrollability and unpredictability in life situations. People with social phobia have a diminished sense of personal control over events in their lives. Cloyter and others, 1992. Evolutionary perspective. According to Oman and others, 1985, social phobias may have developed as a byproduct of dominance hierarchies. Aggressive encounters between members of a social group establish dominance hierarchies where a defeated individual usually displays fear and submissive behavior but rarely escapes from the situation. Thus, people with social phobia are more likely to endure being in the feared situation than to run away. Perhaps, social phobias develop mostly in adolescence and early adulthood when dominance conflicts are most prominent. Preparedness and social phobia. Oman and colleagues, 1985. Have suggested that we humans may have an evolutionary-based predisposition to acquire fears of social stimuli that signal dominance and aggression, example, anger or contempt, from other humans. The researchers have reported that participants develop stronger conditioned responses when slides of angry faces are paired with mild electric shock than when happy or neutral faces are paired with the same shocks. 58. Introduction to psychological disorders and disorders of anxiety and obsessions. Further, even very brief presentations of the angry face that are not consciously perceived are sufficient to activate the conditioned responses. Oman, 1996. 2.7 Treatment of social phobia. Main treatment options used by people for social phobia are cognitive behavioral therapy. Cognitive restructuring along with behavioral techniques has been proved to be more effective as compared to lone use of behavioral therapy. Barlow and others, 2007. The distorted cognitions of client that lead to social phobia, such as, nobody likes me, people do not find me attractive, are identified, and the therapist helps the client to restructure such negative cognitions through reanalysis. During the reanalysis, the client is educated about the origin of cognitive distortions, the automatic negative thoughts, and how these affect the client's social behavior, and restructuring such thoughts by cognitive techniques. For example, questioning the validity of such negative thoughts, taking negative thoughts as hypotheses and logically testing those hypotheses. The clients are also encouraged to do exercises where they are taught to shift their focus from self to others in the situations. Videotaping their social interactions has also been successfully used as a feedback mechanism. Mortberg and others, 2007. Medications. Research has also shown that medications such as antidepressants, example, monoamine oxidase inhibitors, or MAOIs, and selective serotonin reuptake inhibitors, or SSRIs, have been proved to be effective treatment for social phobia. Ipezer and others, 2008. However, further comparative research in this area has reported the cognitive behavior therapy to be more effective than the medications, as it does not involve side effects and relapse rates are also low. Stein and Stein, 2008. Lastly, researchers such as Gostella and others, 2008, have reported that a medication, named D-cycloserine taken in conjunction with cognitive behavior therapy led to faster rates of successful treatment. Disorders of anxiety, panic and obsessions. I-2.8 Clinical aspects of panic disorder. DSM-5 defines a panic attack as a discrete period of intense fear or discomfort, in which at least 4 from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. Although the symptoms must peak within 10 minutes, the attacks often peak within a few seconds and the symptoms gradually subside over a period lasting from a few minutes to about a half hour. Box 2.3 Criteria for Social Phobia according to DSM-5 APA, 2013. A. Recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. Note: the abrupt surge can occur from a calm state or an anxious state. 1. Palpitations, pounding heart, or accelerated heart rate. 2. Sweating. 3. Trembling or shaking. 4. Sensations of shortness of breath or smothering. 5. Feelings of choking. 6. Chest pain or discomfort. 7. Nausea or abdominal distress. 8. Feeling dizzy, unsteady, lightheaded, or faint. 9. Chills or heat sensations. 10. Paresthesias, numbness or tingling sensations. 11. Derealization, feelings of unreality or depersonalization, being detached from oneself. 12. Fear of losing control or going crazy. 13. Fear of dying. Note: culture-specific symptoms, example, tinnitus, neck soreness, headache, uncontrollable screaming or crying, may be seen. Such symptoms should not count as one of the 4 required symptoms. B. At least one of the attacks has been followed by 1 month, or more, of one or both of the following. 1. Persistent concern or worry about additional panic attacks are there. Consequences, example, losing control, having a heart attack, going crazy. 2. A significant maladaptive change in behavior related to the attacks, example, behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. C. The disturbance is not attributable to the physiological effects of a substance, example, a drug of abuse, a medication, or another medical condition, example, hyperthyroidism, cardiopulmonary disorders. 60. Introduction to psychological disorders and disorders of anxiety and obsessions. D. The disturbance is not better explained by another mental disorder, example, the panic attacks do not occur only in response to feared social situations, as in social anxiety disorder, in response to circumscribed phobic objects or situations, as in specific phobia, in response to obsessions, as in obsessive-compulsive disorder, in response to reminders of traumatic events, as in post-traumatic stress disorder, or in response to separation from attachment figures, as in separation anxiety disorder. It is clear from the above list that out of 13, majority, 1 to 10, of the symptoms are physical, whereas only last 3 are cognitive symptoms. In addition to these symptoms, panic attacks may be accompanied by other symptoms as well, example, blurred vision. Panic attacks are experienced across all the anxiety disorders, triggered by a feared situation, object, situation, thought, worry. Many people without an anxiety disorder may experience panic attacks from time to time, example, when giving a formal presentation or taking an exam, or upon encountering some other stressful situation. Panic attacks occur frequently in the general population, with some studies showing that up to a third of individuals experience a panic attack during a given year. Unlike most panic attacks, which are typically triggered by stress, worries, or feared situations, the panic attacks that occur in panic disorder often occur out of the blue, without any obvious trigger or cause. Types of panic attacks: cued or situationally predisposed panic attacks. Panic attacks linked to specific situations such as driving a car. They are strongly associated with situational triggers. Uncued panic attacks. Attacks may occur in unexpected or benign states or in the absence of any provocation, example, in sleep, which is known as nocturnal panic. In case of some people, panic disorder may lead to agoraphobia. In DSM-5, panic disorder is diagnosed as with or without agoraphobia. The term agoraphobia comes from the Greek word, agora, which means market, hence it means a fear of the marketplace. Though it implies a fear of open spaces, however, people having agoraphobia are much more fearful of enclosed spaces, such as tunnels, small rooms, and elevators. Some people with panic disorder develop a concern that they will not be able to make an exit from a crowded place if they have a panic attack. Hence, they avoid going to places where they believe that their escape would be difficult in an emergency, that is, panic attack, and it would cause embarrassment to them. At first, people avoid those situations where they developed agoraphobia, but soon it gets generalized and they begin to avoid not. Panic attack symptoms develop abruptly, usually reach peak intensity within 10 minutes, subside in 20 to 30 minutes, rarely last more than an hour. Anxiety does not have an abrupt onset, symptoms are not as intense as in panic. It is long-lasting. Table 2.1. Distinguishing features between panic and anxiety. 61. Disorders of anxiety, panic and obsessions. Only places outside home, such as market, elevators, public transport, but sometimes places within home also, example, attic, terrace, which they believe would be difficult to escape from. Most but not all, people with panic disorder develop at least some degree of agoraphobia. In extreme cases, an individual with panic disorder and agoraphobia may not leave the house at all. Usually people with agoraphobia are able to leave the house, if someone they know accompanies them whom they believe will be able to help them in making a safe exit in case of a panic attack. Comorbidity. Many people, 83% approximately, suffering from panic disorder with or without agoraphobia also have some other psychological disorders such as GAD, specific phobia, social phobia, depression, substance use disorder, such as smoking and alcohol consumption, and avoidant personality disorder, Bernstein and others, 2006. Prevalence, gender differences in age of onset. Lifetime prevalence for panic disorder with or without agoraphobia has been reported to be 4.7%, but panic disorder without agoraphobia is more prevalent. Prevalence varies cross-culturally, example, in Africa, it was diagnosed in about 1% of men and 6% of women, Hollifield and others, 1990. In Taiwan, prevalence is quite low, perhaps because of a stigma about reporting a mental problem, Weissman and others, 1997. Among the Eskimo of West Greenland, example, kayak angst occurs in seal hunters who are alone at sea. Attacks involve intense fear, disorientation, and concerns about drowning. Panic disorder with and without agoraphobia is more prevalent in women than in men, with a prevalence of 5% and 2%, respectively, Kessler, Chu, and others, 2005c. About 80 to 90% of patients with agoraphobia are reported to be women, White and Barlow, 2002. However, evidence has been found that men with agoraphobia often indulge in self-medication with nicotine and alcohol to endure panic attacks and often do not develop avoidance behavior, as has been found in agoraphobia, Starchevich and others, 2008. Panic disorder is a debilitating disorder. Though its symptoms may increase or decrease at times, however, it has a chronic course. Recovery may take a long time, 12 years as reported in a longitudinal study, with recurrence in 58% of the patients, Bruce and others, 2005. The age of onset has been found to be 23 to 34 years on an average. For women it usually starts in 30s or 40s, Kessler, Chu, and others, 2006. Its onset is associated with stressful life experiences, Pollard, and Korn, 1989. 2.9 Causal factors for panic disorder. The causes of panic disorder involves the interplay of many factors. Biological perspective. Genetic variables. Family and twin studies have pointed toward a genetic component in the development of panic disorder. Kendler and others, 2001, reported a variance of 33 to 43% due to genetic factors in a large twin study that analyzed the factors for inheritability of panic disorder. Like other anxiety disorders, people with neuroticism are more likely to develop panic disorder. Recently, researchers have attempted to find specific genes that are responsible for inheriting panic disorder. However, Strug and others, 2010, Klauke and others, 2010, found no unequivocal results. 62. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Brain activity. Earlier theories suggested the role of locus coeruleus, LC, in the brainstem and norepinephrine, a neurotransmitter particularly involved in the activity of LC in causing panic attacks. Stimulation of this area in the monkeys causes a panic attack. Hence, it was suggested that naturally occurring attacks might be due to overactivation of norepinephrine in LC. Redmond, 1977. Research with humans also found that yohimbine, a drug that stimulates activity in LC, could elicit panic attack in patients with panic disorder, Charney and others, 1987. However, more recent research is not consistent with this position. For example, drugs that block firing in the LC were unable to treat patients with panic disorder, McNally, 1994. Later research found that an overactive amygdala rather than LC is implicated in panic disorder. Amygdala, consisting of a group of nuclei, is located in front of the hippocampus in the limbic system, and its role in emotion of fear has been established through empirical research. Stimulation of amygdala stimulates LC and other autonomic responses occurring during panic attack, Gorman and others, 2000. Amygdala is said to be at the center of the fear network, and is connected to the lower brain areas like LC as well as higher cortical areas like prefrontal cortex. Hence, panic attacks may occur either due to stimulation of lower or higher areas of brain. Dysfunctional biochemistry. Klein, 1981, and Sheehan, 1982, hypothesized that biochemical dysfunctions led to panic attacks, which are the alarm reactions. For more than 2 decades, this hypothesis was supported by several studies. These studies showed that in comparison to normative group, when people with panic disorder are exposed to panic provocation procedure, they are more likely to suffer from panic attacks. The panic provocation procedure involves exposure to biological challenges, such as inhaling air with higher than normal level of carbon dioxide, Woods and others, 1987, taking large amounts of caffeine, UD, 1990, infusing sodium lactate into the body, Gorman and others, 1989, to induce intense physical symptoms such as palpitations, high blood pressure and hyperventilation that is likely to evoke a panic attack. The noradrenergic and serotonergic systems are known to be involved in panic attacks, Grief and Delben, 2008. The noradrenergic system gets activated due to stress and in turn leads to cardiovascular symptoms which provoke panic attack. On the other hand, serotonergic system's activation decreases the noradrenergic activity. This has been supported by the medication results, as drugs used for treatment of panic disorder not only decrease the noradrenergic activity, but it also increases the serotonergic activity. Another neurotransmitter, GABA, which has an inhibitory effect on anxiety, has also been found to be abnormally low in people with panic disorder. Thus, such people suffer from anxiety in anticipation of suffering from another panic attack. Psychological perspective behavioral factors. Several researchers have suggested that a comprehensive learning theory can account for the development of panic disorder, Boughton, 2005, Manika and Zinbart, 2006. Goldstein and Chambliss, 1978, have studied the effect of interoceptive, internal to body, and exteroceptive, external to body, stimuli in conditioning of panic disorder. Through classical conditioning, interoceptive cues, like heart palpitations, stomach ache, and exteroceptive cues such as a place or presence of specific people that were present during the initial panic attack gets associated with it and later on act as triggers for anxiety about future panic attacks, Atchison and others, 2007. In simple words, people end up developing a panic about a panic attack. This also explains the agoraphobic. 63. Disorders of anxiety, panic and obsessions. Avoidance of places like markets or shopping malls, as these serve as exteroceptive cues for an oncoming panic attack. Inhibitory learning, which is required for extinction of a conditioned response, has been suggested to be impaired in panic disorder. Thus, people with panic disorder are unable to learn to discriminate the conditioned stimulus as a safety cue, Lissick and others, 2009. However, panic attacks sometimes seem to be uncued, that is, no trigger, internal or external, seems to be present before the panic attack. This is because panic attack in some cases result from the internal cues that are unconsciously experienced by the individual. This can be understood with an example of a person frightened of a racing heart and who while feeling happy and excited gets a panic attack and is unable to understand the reason of it as she was happy. The panic attack in this case occurred because while feeling happy and excited the person's heart raced, which served as a cue, though not in awareness of that person, for the panic attack. Manika and Zinbart, 2006. Cognitive factors. People with panic disorder have hypersensitivity for their bodily sensations, which are interpreted by them as a sign of an impending panic attack. Beck and Emery, 1985. D. M. Clark, 1986, 1997. The tendency to interpret bodily sensations as a sign of impending catastrophe such as a heart attack, tumors etc. has been called catastrophizing by Clark. Such frightening thoughts start the vicious cycle as it increases the already present physical symptoms of anxiety, which in turn increase the catastrophic thoughts, which in turn triggers the panic attack. It should be noted that the person may be unaware about catastrophizing as these thoughts are out of consciousness. Repay, 1996. Beck has called these thoughts as automatic thoughts which actually trigger the panic attack. However, the cause of developing catastrophizing thoughts is not known. Nevertheless, only those people who have a tendency for catastrophizing develop panic disorder. Example, Clark, 1997. Evidence has been found in line with this theory. Example, Clark, 1997, and Teachman and others, 2007, have reported that individuals with panic disorder have a greater tendency to catastrophize their bodily sensations. This cognitive theory of panic disorder also predicts that the panic can be reduced or prevented by changing people's cognitions about their bodily sensations. Further, likelihood of panic attacks was significantly reduced when people suffering from panic disorder were given a detailed explanation of what physical symptoms to expect when injected with sodium lactase in a panic provocation study. Clark, 1997. Schmidt and others, 2006. Both learning and cognitive theories provide explanations about panic attack. However, the main difference between the two theories is the emphasis that the cognitive theory puts on the meaning that people with panic disorder give to their bodily sensations. Such interpretation of bodily sensations is not necessary for conditioning, as the interoceptive or exteroceptive stimuli could be outside the realm of awareness. Boughton and others, 2001. In the light of this difference, learning theory is better able to account for uncued panic attacks as well as panic attacks while sleeping, as both occur in the absence of automatic cognitions. Anxiety sensitivity and perceived control. Several explanations have been provided that can find support in both learning and cognitive perspectives. For example, McNally, 2002, and Pagura and others, 2009, found that people with hypersensitivity to anxiety are more likely to develop panic attacks and subsequently panic disorder. Interestingly, some studies have also shown the role of perceived control in reduction and even prevention of panic attacks. Example 64. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. In a panic provocation study, if a person has a control over inhalation of carbon dioxide, inhalation of CO2 is known to bring on panic. The possibility of suffering from a panic attack is reduced significantly or even blocked. Example, Sanderson and others, 1989. Zevolensky and others, 1998, 1999. Further, Bentley and others, 2012, have shown that anxiety sensitivity interacts with perceived control for the development of panic attack. That is, lower the perceived control, greater was the effect of anxiety effect on panic disorder. Lastly, higher the perceived control over emotions and threatening situations, lower was the agoraphobic avoidance as the person feels in control of the situation. Suarez and others, 2009. White and others, 2006. Safety behaviors and the persistence of panic. Panic disorder once developed is maintained despite contrary evidence. That is, someone who has always suffered from a panic attack about having a heart attack on finding her heart racing but never actually had a heart attack should understand that a racing heart does not lead to a heart attack. But this logic does not prevent a panic attack, because each time the person was apprehending a heart attack she indulged in a safety behavior, like slow breathing, and believed that this safety behavior prevented the heart attack. Thus, the safety behaviors maintain the panic disorder. Thus, people with panic disorder should be persuaded to abandon the safety behaviors. so that they could realize that their indulgence in safety behaviors does not prevent the heart attack or any other impending fatality like fainting. Clark, 1997. Salkovskis and others, 1996. Research suggests that dropping of safety behaviors by people with panic disorder increased the effectiveness of the treatment. Rachman and others, 2008. Cognitive biases and the maintenance of panic. People with panic disorder have a tendency for processing the threatening information in a biased manner. For example, such people interpret the ambiguous bodily sensations as well as other ambiguous situations as more threatening than the people in the control group. Clark, 1997. Teachman and others, 2006. Also, such people have a biased attention also as they focus more on the threatening information, such as words indicating panic like palpitations, numbness, fainting, etc. Lim and Kim, 2005. Matthews and McLeod, 2005. fMRI studies have shown greater activation of memory areas that are involved in processing information about threatening stimuli in people with panic disorder than the normative group. Maddock and others, 2003. However, the role of biased information processing as a cause or as a symptom of panic disorder remains unclear. Overall, it can be concluded that both biological and psychosocial factors have been found to play a role in the development of panic disorder, and neither of the two in isolation can explain its development. 2.10 Treatment of panic disorder. The approaches to treatment of panic disorder are as follows. Exposure therapy. As explained in the above section on phobias, exposure therapy for agoraphobia and panic involves exposing the client to the feared situation for a long period of time, often in the presence of the therapist or a family member. The underlying idea is that the client, on being exposed to the feared situation for a long time without eliciting any harmful effects, help him, her to realize the futility of his, her. 65. Disorders of anxiety, panic and obsessions. Agoraphobia with panic attacks. This exercise has been shown to be effective in treating 60 to 75% of people with agoraphobia and a maintenance rate of 2 to 4 years. Barlow and others, 2007. A limitation of this therapy was that it did not deal with panic disorder specifically. Hence, another technique, known as interceptive exposure, was devised to deal with panic attacks in 1980s. This technique involves causing internal bodily sensations such as spinning head, nausea, breathlessness, which are associated with panic attacks, with the help of activities like seating a client in a spinning or rocking chair. When the client undergoes a prolonged exposure to such situations without getting a panic attack, the association of the internal bodily cues to panic attacks gets extinct. Integrative technique. Cognitive restructuring integrated with exposure therapy used specifically to treat panic disorder is known as panic control treatment. It involves educating the client about the role of catastrophic automatic thoughts in causing and maintaining the panic disorder. During the therapy, the client is taught to identify the negative automatic thoughts and dispute those in a logical manner, using techniques like hypothesis testing and humor. Then the client is exposed to the panic-eliciting situations, both internal bodily sensations and external cues, to develop tolerance against the discomfort caused by such situations. This helps the client to deal with panic-causing situations efficiently. Research evidence has shown the integrative technique to be more effective than using either the exposure or cognitive restructuring technique alone. Arch and Kraske, 2009. It has proven to be effective in 70 to 90% of clients, and maintenance rate of 1 to 2 years has also been reported. McCabe and Gifford, 2009. Medications. Medicines like anxiolytics, anti-anxiety drugs, and antidepressants have also shown to be effective in treating agoraphobia and panic. Researches, however, conclude that both drugs have advantages and disadvantages also. Anxiolytics, which belong to the category of benzodiazepines, include drugs like alprazolam or clonazepam, which have been shown to treat acute episodes of extreme anxiety, as these drugs work quickly, within 30 to 60 minutes. However, these also have side effects such as drowsiness, sedation, impaired cognitive as well as motor performance. Additionally, physiological dependence may also develop because of prolonged use and lead to withdrawal symptoms like sleep disturbance, dizziness, and panic attacks. Relapse rate is also quite high. Pollock and Simon, 2009. Antidepressants including tricyclics, SSRIs and SNRIs, serotonin norepinephrine reuptake inhibitors, used for treating panic disorder and agoraphobia also have advantages and disadvantages in comparison to anxiolytics. Some advantages of antidepressants are that these treat the comorbid depression and do not lead to physiological dependence, Pollack and Simon, 2009. However, a disadvantage of antidepressants is that in comparison to anxiolytics, these take longer time, approximately 4 weeks to act, hence, cannot be used in acute cases of panic disorder. Other side effects include dry mouth, severe constipation, blurred vision, etc. Lastly, relapse rates are quite high when discontinued, Roy Byrne and Cowley, 2007. Though a combination of cognitive behavior therapy and medication therapy has found to be slightly more effective, Barlow and others, 2007. However, it has been found that once the medication is discontinued, relapse is common as perhaps many of the clients attribute their treatment gains to medication, Mitty, 2005. 66. Introduction to Psychological Disorders and Disorders of Anxiety and Obsessions. Nevertheless, a drug named D-psilocybin used in combination of CBT has shown promising results, Otto and others, 2005, are generalized anxiety disorder, specific phobia, social phobia, panic disorder, and agoraphobia. A phobia is a persistent and disproportionate fear of a specific object or situation that presents little or no actual danger to a person. According to DSM-5, specific phobia, previously known as simple phobia, has 5 subtypes: animals, example, snakes, spiders, dogs; natural environment, example, water, heights, storms, blood injection injury; situational, bridges, tunnels; others, vomiting, choking; space phobia, where the person has a fear of falling down if she is away from walls or support. Phobias develop as a result of psychological, behavioral, biological, evolutionary, or cognitive factors. A social phobia is a persistent, irrational fear generally linked to the presence of other people. It can be extremely debilitating. The difference between social phobia and social anxiety disorder, SAD, is largely chronological, in that social phobia is the former term and SAD is the current term for the disorder. Panic disorders are characterized by panic attack which are a discrete period. 67. Disorders of anxiety, panic and obsessions of intense fear or discomfort, in which at least 4 from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. Panic attacks are experienced across all the anxiety disorders. Cognitive behavior therapy and medication is found to be effective in the treatment of panic disorder. 2.12 Keywords: anxiety. Feeling experienced only in anticipation of danger, threat when such a danger, threat is not present or cannot be specified. Comorbidity. When 2 or more disorders or illnesses that occur in the same person. Panic. Subjective feelings of impending doom, fear of dying, going crazy and losing control. Panic attack. Discrete period of intense fear or discomfort, in which at least 4 from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. Gamma-aminobutyric acid or GABA. Inhibitory neurotransmitter that helps to keep the feeling of anxiety away. Corticotropin-releasing hormone, CRH. The CRH plays a role in GAD as it is an anxiety-producing hormone. Phobia. A phobia is a persistent and disproportionate fear of a specific object or situation that presents little or no actual danger to a person. Social phobia. A persistent, irrational fear generally linked to the presence of other people. It can be extremely debilitating. Agoraphobia. A fear of agora, Greek word for public places of assembly or marketplace. It is a fear of crowded places. Technique help in the treatment of panic disorder. Thank you for listening. Please like and subscribe our channel.